This is a transcanal surgery done for a deep posterior superior retraction pocket. As we can see, the tympanomeatal flap has been elevated. This is the right side. And with the tympanomeatal flap elevated, we are operating through a self-retaining Omgren's ear speculum. This surgery can be done both endoscopically and microscopically. Here we are using a microscopic approach because it gives us a very good manual dexterity, the ability to use both hands together with suction in one hand and the instrumentation in another. Here you see we are gradually sharply excising the adherent epithelium from the scutum on the right side, and what you see is the vision of the footplate. The residual portion of the stapes head is imbibed in the pocket is also visible. So the stapes superstructure is grossly eroded. Some portion of it that is imbibed in the elevated pocket is also being now cut sharply. We are avoiding use of lot of blunt trauma by merely pushing so as to avoid any trauma to the footplate region. And in between, we use the sharp dissection to keep cutting the epithelium from this region. Some amount of scutum has been drilled in this patient. The chorda has been resected to give us a better exposure of the posterior superior region and the oval window region. The incus long process was completely eroded, and as you can see, the stapes superstructure is now part of the epithelium that has also been pushed back with the tympanomeatal flap, which shall be later on resected together. Now what you see is the pearly white vision of the stapes footplate, which is completely engulfed with the squamous epithelium. This is particularly a precarious situation and requires the maximum amount of finesse and gentle surgery to clear this epithelium 100% in toto from the footplate region. The integrity of facial nerve is important. You see how this epithelium is now being very slowly and cautiously elevated from the footplate region from inferior to superiorly and from anterior to posteriorly. So you see here how from the promontory side first, this epithelium is elevated with the smallest of suctions, 23 or 24 gauge suctions with a sickle knife. One can also use a slightly curved needle for this purpose. The most important part here is to have a clear vision of the footplate region, not to let the instrumentations overshoot or puncture the footplate to cause any vestibular leak, nor to be too rough with the movements. And at all point of time, it's very important to maintain the exact trajectory of the instrumentation and very fine movements so as to not affect the integrity of the footplate and just clear the epithelium. The epithelial clearage also has to be 100% because leaving any squamous epithelium over this region can be catastrophic. If one has doubts over the integrity of the facial nerve, which means the integrity of the fallopian canal, then one also cannot use laser over this step because then that has a potential to cause facial nerve damage. So you see how it takes a lot of time and patience to clearly use both the hands and two-handed instrumentation to very progressively, slowly, but persistingly elevate epithelium from the oval window region. And this is perhaps one of the most intricate steps in middle ear surgery to clear epithelium from an intact mobile footplate, which is something that should be left to senior surgeons, because this is something where when causing any trauma to the footplate, a fracture or subluxation of the footplate can lead to irreversible hearing loss in the patients. These pockets are often contaminated with infection, with bacterial biofilms, and so clearing them 100% without causing any breach in the labyrinth or the vestibule is fundamentally important. Now you see in between how we use sharp dissection from an iris scissors along with our blunt dissection. The iris scissor has to be fine enough to go inside and be able to open. And as you see, very slowly and steadily, the footplate region appears to be getting cleared of all the epithelium. Now, most of that epithelium, along with the fractured stapes head and the rest of the posterior superior retraction pocket, is now being held together with the tympanomeatal flap, which in the end shall be resected in toto. The goal here is to clear the disease from the footplate region, the vestibule, and to reconstruct the middle ear hearing mechanism in this young patient using a total ossicular replacement prosthesis. We normally avoid using cartilage struts because they get adhered to it very badly and sometimes also get reabsorbed over many years. So we prefer using a total titanium ossicular replacement prosthesis or TORP, which we shall be using in this patient, and we shall be using a cartilage, a full thickness cartilage graft taken from the tragus to cover the head of the total ossicular replacement prosthesis. Now see how you place the tympanomeatal flap back to see the integrity of the same. While the disease from the footplate has been cleared, and now what remains is to take a cartilage graft from the tragus, prepare the footplate for a TORP prosthesis, and then cover the head of the prosthesis with a full thickness cartilage graft to avoid both a retraction as well as any contact of the neodrum to the bare prosthesis and to avoid its extrusion. So any implant from our side, whether it is hydroxyapatite or titanium, the head should be always covered with cartilage, either full thickness or partial thickness. Now you see how we are resecting the attached epithelium to the tympanomeatal flap, which includes also the epithelium that we have removed from the stapes footplate, as well as the remnant of the crux, that is portion of this excised and pedicled epithelium. We can see a clear view of the footplate region now, which is bare and 100% intact. It's very important to not leave any squamous epithelium in the middle ear because that can lead to iatrogenic cholesteatoma formation. So once again, we resort to sharp excision and sharp dissection to clear, and now we see a very good clean view of the middle ear. Once the middle ear has been cleared, we use the tragus for a microscopic approach, and here you see we have placed a titanium TORP, a TORP prosthesis over this is a standard 4.5 millimeters implant, which is slightly bent to basically increase or decrease the length of it. This 4.5 millimeters seems to fit well. It has to be very carefully positioned over the footplate and to be made sure that this stands tall at the right angle and with the edges not in contact of the scutum or the posterior superior canal wall, because then that would dampen the vibrations of the prosthesis. Now, one should remember that every bit of angulation or positioning can affect the overall hearing of the patient. So this must be as perfect as possible. And now you see we're using a full thickness cartilage graft over the head plate, where the lateral side, or the side that faces the external auditory canal, is having attached perichondrium, whereas the one that is facing the implant is the bare side, and the perichondrium that we have achieved removed from the fecal cartilage graft, we shall be using it if required over this. As you see, the tympanomeatal flap is being placed back over the cartilage assembly. We've used one larger and a very small palisade to cover the graft.